renal disease is our session today, and the learning objectives for this session are: describe the antibody-mediated nephritis in relation to fixed glomerular antigens, discuss glomerulonephritis associated with immune complexes, discuss the immunopathological mechanism of glomerulonephritis to trapped glomerular antigens. Now, nephritis, first of all, it's the inflammation of the nephrons, and most of the glomerulonephritis, the underlying mechanism is immune mediated. And there are three proposed, the three proposed classification methods are that either there is a fixed glomerular antigen or antigen is trapped in the glomerular basement membrane. And the example of this is, of course, anti-glomerular basement membrane disease. Then the immune complex mediated is a huge number of diseases which are actually caused by immune complexes, and the diseases that we'll be discussing today are post-streptococcal glomerulonephritis, lupus nephritis, and IgA associated glomerulonephritis. Then there is a tuft of capillaries in the Bowman's capsule, as you all might know, and when those small capillaries are inflamed, that is called as vasculitis. And there are also conditions which are associated with vasculitis, and they include Henoch-Schönlein nephritis, Wegener's granulomatosis, or polyangiitis. Since immunopathological mechanism is the most important thing related to all these nephritis, there are certain mechanisms. So I'll go step by step and explain it. So the whole, there's a big bulk of diseases that are related to immune complexes, and immune complexes normally, physiologically, antigen binds to antibody and they tend to produce immune complexes in the body, but they have to be removed from our body very efficiently. And if in case there is a excess of antigens or antibody, or there is a deficiency of their removal, or there is incomplete removal of these immune complexes, they tend to be deposited in the glomerular region or in the tubulointerstitial region. Then, as I mentioned, if the tuft of capillaries are inflamed, such condition is termed as vasculitis, and the ANCA antibodies are specifically related to the vasculitis. These antibodies also cause damage to glomerular basement membrane or the tubulointerstitial region. And sometimes specific antibodies, for example, the immunoglobulin A in case of IgA nephropathy, they can act as trapped antigens. And at times the structural component of the glomerular basement membrane itself acts as antigens, and antibodies are produced against them. So whichever of these cause is there, it will either result in initiation of damage to the glomerular region or to the tubulointerstitial region. Then there are certain key cells or players involved in this, and these cells include the epithelial cells, the endothelial cells, and the mesangial cells in the glomerulus, which are actually affected by this attack immunological mechanism, and the mediators are released. Now, I can link at least this immune complexes very clearly. The IgM antibodies, when they bind to the antigens, form immune complexes. These complexes are capable of activating the classical complement pathway, which in turn lead to the MAC formation. Here there will be MAC formation, and as well as the polymorphic activation. So these they result in MAC formation, and here these polymorphic activation means that the neutrophils will be called upon by C3a, C4a at the site of inflammation. C3a, C4a C5a, and at the same time there are coagulation factors that are triggered, kinin activation take place, vasoactive amines actually play a very important role, like histamine, prostaglandin, leukotrienes, and a lot of cytokines, in particular the pro-inflammatory cytokines, the IL-1, IL-6, and TNF-alpha. So these are all produced by this activation at the glomerular region or at the tubulointerstitial region. So what will happen? It will result in glomerulonephritis or tubulointerstitial nephritis, which further leads to the clinical syndrome of acute nephritis, nephrotic syndrome, proteinuria, renal failure, hematuria, or tubular dysfunction. We can, investigate these patients with, of course, after taking their history, their clinical examination, and the baseline investigation. But all of that sometimes does not give us a very conclusive, evidence, and we cannot confirm our diagnosis. That's why renal biopsies are very important in diagnosing the glomerulonephritis. Not, of course, all of them, but we'll see today that in a lot of the cases, the renal biopsy is very important. Now, once you take the renal biopsy, you can do certain things with them, like the light microscopy is done, and you can do the EM, electron microscopy, or immunofluorescence. And they all help in finally reaching your diagnosis. They have three main patterns that you see. One is the linear staining, the linear staining of the renal biopsies, or granular staining, and sometimes there is a minimal complex deposition in the biopsies. But of course, what you have to bear in mind that the additional features, these features are very important. You have to take these into consideration along with the renal biopsy, and this is when you will reach to this final conclusion, which you see at the base, at the bottom. So let's say there is a linear staining of the glomerular basement membrane. It's kind of straightforward, and most probably you should think of anti-glomerular basement membrane disease. Anyways, you also see a linear pattern in diabetic nephropathy as well. The granular staining, this can be seen in a lot of conditions, but if we pay attention to the conditions that we are going to discuss today, these three, the IgA nephropathy, lupus nephritis, and post-infective glomerulonephritis, these three are actually linked. So this granular staining is linked with the added feature. The IgA nephropathy, the patient tend to have excess of IgA in their serum, and it is then linked to the special staining pattern, which we'll discuss later. Lupus serology, so of course these are patients of systemic lupus erythematosus, and then they have lupus serology positive, and you might all remember that the double-stranded DNA antibodies, ANA antibodies, or anti-Smith, anti-histone, these are all the long list of antibodies that are present in the systemic lupus patients. Not all of them, of course, and when you add up that with the granular staining, you can confirm the lupus nephritis. And the evidence of acute bacterial infection is very important, and later you can see in the biopsy certain features that help you confirm post-infective glomerulonephritis. And these are the conditions that we'll be focusing today. On any renal biopsy, there are certain things that you might observe. As I already mentioned, either there will be a granular staining. So you can see this is a granular staining in the tubular region, and this is the granular staining in the interstitium. This is the granular staining that you see in the capillary. This is the capillary loop. These are the mesangial cells. So these are the mesangial cells. Then this is the interstitium, and this is the tubular region. So you can see granular staining in all of them, and also you might see linear stain in both the regions. So it's not that linear staining will only be seen in this part. You can see that a linear staining also in the tubular region. So either you see linear staining or you see granular staining, and which type of, whether that granular staining, then you can further confirm, is it the presence of IgA antibodies, IgG, IgM, which complement proteins are there, C3, C4. So all that then help you identify which particular disease it is. Now, immune complexes are actually very important in this whole underlying mechanism theory. And before I explain this, I'll just quickly explain this diagram. Here is the glomerular basement membrane. It's the blood is flowing here inside. Outside is the urine. These pink cells are the endothelial cells, and these is the glomerular basement membrane. These are the epithelial cells with their food processes, which are termed as podocytes. Now, this is in case of normal physiology. Everything is fine. There are no immune complexes, so you don't see anything. But if there are intermediate size complexes, and if they are in antigen excess, then what will happen? They will first very rapidly deposit. They will cross the endothelium, the basement membrane, and they will deposit here at the subepithelial region. And example is acute proliferative glomerulonephritis, and the conditions are post-streptococcal glomerulonephritis, PSGN, or lupus nephritis. So in both these conditions, the size of the complexes are kind of small, and there is an antigen excess. But if the size become slightly more bigger, then what will happen? These antigens are then, the immune complexes are then going to cross slightly slowly, and you can see the change in the deposition. Here you see the humps. You see, these are humps which are seen in the subepithelial region. But in this case, the direction is opposite. Now they are turned into spikes. They are turned into spikes. So the slightly bigger the complexes, they deposit slowly, and then they create a different morphology. They create the spikes. An example of this is membranous nephropathy, and this include the it can be caused by drugs like penicillamine or gold salts, or it can also be caused by infections like malaria and syphilis. Then let's see what happens to the large complexes. Of course, as you might imagine, large complexes are not able to cross the glomerular basement membrane. In fact, they are stuck in this region, and they immediately deposit close to the endothelium. And this is seen in membranoproliferative nephritis, especially the type 1, which is either caused by hepatitis or malignancies. And another thing I just forgot to mention, in case of this slow deposition, when the immune complexes are deposited here and there is inflammation triggered, you can compare these foot processes. You can still see the foot processes here, but here these foot processes are kind of gone, and this is called as effacement, podocytes effacement. So when you are not able to see the foot processes, they are called as podocyte effacement. Complement system actually has a very interesting relationship with the immune complexes. As I mentioned, there is a continuous formation of immune complexes in the body as we face different infections, and then these immune complexes are disintegrated and then removed from the body. And both the different pathways have different role to play. The classical pathway activity actually prevents formation of insoluble immune complexes. So classical pathway, it tries to prevent the formation of immune complexes, whereas when the complexes are formed and their size become bigger, it's the alternative pathway which disrupts the large immune complexes. Then, interestingly, we saw already that when the complement system is activated, it also acts as a mediator of immune, mediated tissue damage. The MAC formation take place, the C3, C4a, C5a, they are produced, more inflammatory immune cells are called upon. So complement system has a different way of dealing with the immune complexes. The immune complexes activate different pathways and they result in tissue damage, but at the same time these complement proteins are also responsible for removing them from the body to keep a balance. But in case of excess immune complex formation, excess complement activation, the complement proteins are used up. C3, C4 levels are kind of reduced, and it's actually they are consumed, and their levels are measured, at a regular interval, and they give us a very important insight into the disease, which is, they tell you about the prognosis of the disease. So let's say, for example, in case of lupus nephritis, you will keep measuring these complement proteins, and as the patient improves with the treatment, these complement proteins should go back to their normal level. Now we'll start with our first. So the first clinical scenario is a 9-year-old boy brought to the emergency with puffiness of face, eyes, and trunk. A week previously, he had complained of sore throat. On examination, he's found pyrexial with the temperature 30 degrees and hypertensive, anemic with normal WBC counts. Urine analysis shows proteinuria, hematuria, and red cell counts. There is a raised anti-streptococcal O titer, which is 1600 international units per ml, and normal is less than 300 international units, and complement protein were very low, especially C3 and C4. Now there is a question, what is the role of anti-streptococcal O in this case, and should we perform a renal biopsy, and what will happen to the ASO and complement levels? So I don't know, should I be doing a poll from the students, or anyway. The first thing is that this particular condition, you might have noticed that it's a case of post-streptococcal glomerulonephritis, and the post-streptococcal glomerulonephritis is caused by group A beta hemolytic streptococci. It's an acute condition. It's just a matter of 1 to 3 weeks that results in the features of proteinuria and hematuria. 90% of cases affect children between the age of 2 and 14 years, and 10% of the cases are patients older than 40 years. Post-streptococcal glomerulonephritis is seen after impetigo and post-streptococcal pharyngitis. In case of impetigo, it's 2 to 6 weeks after the skin infection. You see the features of clinical features of nephritis, while in case of pharyngitis, it takes just 1 to 3 weeks after the infection for the clinical features of nephritis. Before I go into the management, so there are certain antibodies that are found in the patients of post-streptococcal glomerulonephritis. They include the anti-streptococcal O, which is actually an enzyme that are produced by these bacteria, and there is anti-streptokinase or anti-hyaluronidase. These antibodies. Actually, they are very helpful in around 90% of the cases of the streptococcal disease patients. You will find the presence of these antibodies, and once they are on treatment, around 4 weeks later, there is a significant drop in these antibodies that are seen in these patients. The management of this patient is treatment supportive with control of hypertension, edema, and dialysis is needed. And antibiotic treatment for streptococcal infection should be given to all patients and their cohabitants. And there is no role for immunosuppressive therapy even in the settings of crescent. If the biopsy is done, normally the biopsy is not recommended. The reason is because it's very short acute duration, and mostly it is seen in little children. There is a history of pharyngitis or pyoderma, and when they are put on antibiotic therapy, they tend to respond very quickly, and there's a remarkable drop seen in the antibody titer. So there is no need of going through this invasive procedure. The second scenario is a 39-year-old woman was diagnosed with systemic lupus erythematosus 20 years ago. She developed the clinical features after the birth of her second child. The pregnancy was complicated by proteinuria. The patient had polyarthralgia, alopecia, and erythematosus rashes of the face, arms, and legs. A renal biopsy was performed because her urine analysis revealed proteinuria and red blood cell casts. What to expect on renal biopsy and how antibodies mediate damage in this particular condition. I'll first show how the damage is done, or what causes the damage in a sequential way, and what to expect on the renal biopsy that we'll see later. So it's a case of lupus nephritis. After systemic lupus erythematosus, 30 to 50% of SLE patients will have clinical manifestation of renal disease at some time of diagnosis. Adults 60% and children 80% develop renal abnormalities at some point in the course of their disease. Now, antibody-mediated damage in lupus is seen first. As we might expect, there will be a lot of immune complex formation in these patients. These immune complexes are going to trigger the complement activation, in particular classical pathway, and there will be MAC formation, there will be other complement protein synthesis, and there will be leukocyte infiltration of the glomerulus. And finally, there will be release of pro-inflammatory cytokines and the presence of the leukocytes. They will all together cause damage to the glomerulus. Now, there are certain investigations that are done in these patients. There is complement proteins are measured, and because of the consumption, there is hypocomplementemia is common in patients with acute lupus nephritis. 70 to 90% tend to have this. On renal biopsy, the morphological variants of lupus nephritis are seen. Actually, the WHO has suggested a criteria for classifying the lupus nephritis patients. So there are 6 classes, starting of course with a normal, and then later on there is membranous, there is proliferative condition seen sometimes, then it become diffuse mesangial cell deposition is seen, and finally the 6th stage is glomerulosclerosis. So there is a lot of information that is present in the renal biopsy of different patients. So renal biopsy is a must. A patient with crescents on biopsy may have a rapid progressive decline in renal function. Now, here is there are 3 figures that shows different features. This one is a light microscopy, and this one is an electron microscopy, and this figure is of immunofluorescent staining. On light microscopy, what can be seen? Hypercellularity of the tuft. So a lot of inflammatory cells. You can see all these black dots. These are the immune cells that have come in, and there is a lot of hypercellularity of the tuft because of the infiltration. In this electron micrograph, you can see this is subepithelial deposits, or the humps, which we saw in the immune complex deposition. When they are small and the antigen is in excess, they directly deposit and create this hump. And then on the immunofluorescent staining, they have got granular staining of the whole glomerulus, and importantly, there is staining of IgG, C3, C4, C5, C9, and when the immunofluorescence of the lupus patient is done, they give it a special name, which you'll be hearing in the future. It is called as full house appearance. It's called as full house appearance. When all components can be seen, Ig, C3, C4, C5 to C9, and they have a granular staining. So when most of the different antigens are seen on the immunofluorescent, it is termed as full house appearance in lupus nephritis. The next case is a 14-year-old boy presented with an 18-month history of intermittent painless hematuria, usually after active excess, but without dysuria or increased frequency of micturition. He also had frequent colds and sore throat. On examination, he was fit, healthy, with a blood pressure of 120/75, and the investigations reveal urine analysis, hematuria 3+, trace of protein, micturating cystogram and cystoscopy were normal, and hemoglobin, WBC count, blood urea, creatinine clearance, complement C3, C4, and hemolytic complements 50 were all normal. What should be done next, and what do you expect? So the first thing is, if you look, there are a lot of clues at the history itself, and a lot of things have been ruled out. So when there is no dysuria and no increased frequency of micturition, this is to rule out diabetes. He also had frequent colds and sore throat. On examination, he's fit and healthy. The cystogram, normally the presence of hematuria is related to either stones or tumors. So cystogram and cystoscopy were normal, and as well as hemoglobin and WBC counts. The renal function are also normal. Complement proteins are normal, so it's not in straight away, complement consumption is not taking place. So what should be done next, and what do you expect? So first thing is, we'll discuss what IgA nephropathy is and then the answers to these questions. IgA nephropathy, this is a case of IgA nephropathy or Berger's disease, and IgA nephropathy is one of the most common forms of glomerulonephritis worldwide. There's a male dominance and peak incidence in second and third decade of life, and it's have a rare familial clustering. Circulatory IgA concentration is increased in up to 50% of the patients. Now, there are a few things I'll just explain here. Normally, IgA antibodies are of two types. One is called as IgA1 and one is IgA2. These are monomeric, while these IgA2 are dimeric in form, and they have a secretory component to it. And at the hind region, there is a process which of galactosylation. And this galactosylation actually helps in the degradation of these antibodies. But what happens if this galactosylation is deficient or it is defective? Then their degradation will not be normal, and these IgA1, which are mainly present in the serum, their quantity will be increased, and it's too much increased that up to 50% of the patients, their concentrations are very high, and then the antibodies, IgG antibodies, are produced against this defective glycosylated part. That's how antigen antibody complexes are formed in case of IgA nephropathy. And it may rapidly progress to renal failure. So that's why a biopsy is very important. And what you see in these renal biopsy is that especially the IgA antibodies, these defective IgA antibodies, they are deposited in the mesangium. So actually there are three different types of cells in relation to the glomerulus: the epithelial cells, the endothelial cells, and the mesangium. So the epithelial cells, the endothelial cells, and the mesangial cells. These mesangial cells are actually very much involved in the process of removal of debris, and somehow these IgA immunoglobulins, they are mostly deposited close to the mesangium, and these mesangial cells are outside the capillary loop into the as a supportive core. So what you see here is in this immunofluorescent staining, there is a granular staining, but it's particularly of the mesangial cells, and this electron micrograph here shows the IgA deposit. This is the IgA deposit, and this is the mesangial cell. So this is a typical feature of IgA nephropathy. So yes, of course, the answer to the question which were asked initially is that the renal biopsy will be done in these patients, and this will show the granular staining, and particularly close to the mesangial cells. The next case is anti-glomerular basement membrane disease, or anti-GBM, when they are present with lung hemorrhage and glomerulonephritis. They have a pulmonary renal syndrome called good posture syndrome. So normally anti-GBM is seen in two age groups: in young men, that is in the late 20s, or men and women between the age of 60 to 70 years. Disease in younger age group is usually explosive, with hemoptysis, sudden fall in hemoglobin, fever, dyspnea, and hematuria. The cause for this is actually the type 4 collagen proteins. They have a chain called alpha 3. It's the antibodies are produced against these, and that triggers the damage to both the alveolar basement membrane and the glomerular basement membrane. So both the membranes have got type 4 collagen fibers, and these collagen fibers have got alpha chain, and that alpha chain is targeted by the antibodies, and that's why you see the features of lung hemorrhage as well as glomerulonephritis in cases of good posture syndrome. And an urgent kidney biopsy is needed to confirm the diagnosis and assess the prognosis, because it's a very aggressive disease, and we need to confirm it is really anti-GBM, and then manage the patient accordingly. So renal biopsies typically show focal or segmental necrosis. So normally, the extent of the damage on a renal biopsy can be, it can be focal, it can be segmental or diffused. Focal means that some glomeruli are involved. The segmental means a part of a glomerulus is involved, or the lesion is involving part of the glomerulus, and the diffuse means that more than 50% of the glomeruli on the section are involved. So in this case, they can be focal or segmental necrosis with cellular proliferation, and this proliferation is of epithelial, endothelial, or of the mesangial cells. There is linear immunofluorescence staining of IgG, and rarely IgA antibodies are seen. So this is the thing you can see. This is called as a crescent shape of the fluorescent staining, and it mainly occurs because the epithelial cells, the parietal epithelial cells of the Bowman's capsule, they are proliferating. When they are proliferating, they kind of push these glomeruli, and they are kind of pushed and crushed. This is also termed as crushed ribbon appearance, and this pushing gives it a crescent shape. And of course, it's linear, it's straight, it's not granular as we saw in the other cases. So prognosis at presentation is worse if more than 50% of the crescents on renal biopsy with advanced fibrosis, if serum creatinine is more than 5 to 6 milligram per dl, and there is oligoid present, so there is need for acute